tonight is going to be about sleep apnea. I'm from the East Northport Public Library. Still got people joining. And we are hosting this program on behalf of the public libraries of the town of Huntington. So we have Cold Spring Harbor, Comac, Elwood, Half Hollow Hills, Harbor Fields, Huntington, and South Huntington Public Libraries. So thank you for joining us. If you could please stay muted during the PowerPoint presentation, we would appreciate that. At the end, we will have time for a Q&A period with the doctor. You could also use the chat feature during the presentation, and we'll make sure we get to any of your questions at the end. So I'm going to hand this over to Dr. Wohlberg. There you go.
Okay, good evening, everybody. So I'm going to do an overview of sleep apnea for you, what I frequently tell my patients, and then I'll take a question and answer. I don't expect that my lecture will take more than 20 to 30 minutes. If I go too fast, try to stop me. In any case, first slide. So this is what we usually think of when we hear sleep apnea. Somebody fell asleep at the wheel of a train, went too fast around a curve, and had a catastrophe. This is how I usually get introduced to sleep apnea. Many of my referrals have to do with a person who's a bed partner being annoyed by the snoring, and frequently people are sleeping in separate rooms. Normal sleep goes through stages. You start out in stage 1, which is really reverie. Most people who are, awakened in stage 1 say that they were just sort of daydreaming. Stage 2 is the real deal. It's good sleep. It's half the night. Stage 3 and 4 have been combined into something called N3, and that's really repair time. That's when the body gets repaired, muscles and everything else. And REM sleep is an organizer of memory. You clean house and make yourself prepared to think a little bit better in the morning. So they're all very critical, and we all go through these stages 3 to 4 times a night, sometimes 5, through all of them. Sleep disordered breathing is a general topic here, and what's occurring is that as we fall asleep, the muscles that hold our lower jaw and tongue in place. Well, let me go through this first. So as we fall asleep, the muscles that hold our jaw and tongue in place fall asleep, and we start to suck it back. So initially, you may have snoring without any disruption of your sleep. Your partner might be different, and then it becomes a slightly worse obstruction to the breathing that can disrupt your sleep. But for the point of view of the insurers, you have to have something called apneas and hypopneas in numbers in order to be defined as sleep apnea and be eligible for treatments. So this again is showing what I said. The tongue slides back, occludes and blocks the airway. And as you notice, these images are facing upwards. So when you're sleeping on your back looking at the sky, you're more likely to have worse sleep apnea because of gravity. So this is a disorder of breathing problems during sleep. An apnea is one event. That's when you suck it completely closed, no airflow at all for at least 10 seconds. For the insurers, a drop in the oxygen saturation of 3 to 4%. Medicare is 4%. And a disruption of sleep. As if someone slammed on a table next to you in bed, you're up, you fall back asleep, you don't recall it, but you have a lighter, broken up sleep instead of a deep, continuous sleep. Then there are hypopneas. That's where you're starting to suck the airway closed. The airflow rate goes down by 30%, lasts at least 10 seconds, drop in the oxygen level, and a disruption of sleep. What we do in a sleep test is we add all the apneas plus hypopneas. We divide by the hours that you slept, and we get a rate, apnea or hypopnea per hour, which is known as the apnea-hypopnea index, in case you get asked that question on Jeopardy. So normal is considered up to 5 apneas or hypopneas per hour, mild sleep apnea 5 to roughly 15, moderate 15 to 30, and severe over 30. There's no quiz, you don't need to remember this. So who gets sleep apnea? Well, men are much more commonly affected than women. By a significant number until after menopause when women start to catch up. It's a lot of people. It seems to me, since this is what I see, like more than this, 1 in 10 males, 1 in 20 females, occurs mostly as we get a little bit older and possibly a little bit heavier. and it increases in particular in women as they get perimenopausal. Now, it can affect children, but in children it's very different. And while we get to be sleepy, children get to be hyperactive, and
Yes.
it's something to think about, because some of those hyperactive children, including my son, get misdiagnosed as ADHD. And if they're snoring at night, you probably want to find a pediatric sleep specialist, because they may be missing the boat. Something as simple as tonsillectomy or palatal expansion, the upper palate expansion, can fix it. And their schooling will be better. They won't be treated with drugs that might give them headaches. So elevated risk factors: male sex, over 35 body mass index, that's heavy people, over 50 years of age, thick necks. I like to not use the numbers. If someone looks like they have a thick neck, that's a plus in terms of thinking that they might have sleep apnea. Family history: smoking. Certainly alcohol makes it worse at times. Some ethnic origins are a little bit higher. And people who have sort of small mouths for a variety of reasons are also more likely to obstruct, with their tongue being larger relative to their airway. So snoring is a clue. People who wake up choking or gasping during sleep, or maybe have dreams about being confined or underwater, kicking the covers a lot, being tired during the day, headaches in the morning is common. They could complain more of dry throat. Depression is a chicken and the egg kind of things. Bad sleep causes depression. Depression causes bad sleep. As I mentioned, if you have disruptions during REM sleep, which is more common because there is inhibition of all the muscles that might help you so that we don't act out our dreams during REM sleep, you'll have memory and concentration problems because that organizing step is interrupted. Sexual dysfunction: people with erectile dysfunction are more likely to have sleep apnea and can respond to treatment. Reflux: if you're making a negative pressure in your chest, sucking against a closed airway, you're more likely to suck acid up as well. High blood pressure: when you have all of these disturbances, each time your brain is aware of a problem breathing, it's an emergency. Oh my God, someone's got a pillow over my face, I'm going to die. You pour out adrenaline, and in a hyperadrenergic state, you can have high blood pressure and you can have arrhythmias. And we mentioned ADHD in poor grades, and not being confused that sometimes it's a sleep disordered breathing and not ADHD at all. So we're going to get into consequences. Murder is not a big one. And, fatigue, unrefreshing sleep, headaches, more higher incidence of strokes. Bad sleep in general makes the threshold to seizures lower. We mentioned choking and gassing, chest pain. All of these things are involved. I'll get into the major ones in a minute. So there's a higher incidence of sleep apnea and obesity. There's a higher incidence of diabetes, congestive heart failure, hypertension, and stroke, really through a mechanism of general inflammation in people who have sleep disordered breathing. So it's important to find it because these things can improve with treatment. That is not a real sleep disorder that I know of, but I suppose it could be. Okay, so the lack of early diagnosis and treatment cost money. This is William Dement, is the founder of sleep medicine. He died a few years ago. He certainly was a inspiration to me. I did go out to Stanford. I met him early on in my career. And the kinds of things are, include high blood pressure, as mentioned already, diabetes, reflux. There are more motor vehicle accidents, like that first slide with the train derailment. Workplace accidents are more likely, and lost productivity because you're tired or absent from work. And it's a lot of money. This is, these are the slides that are meant for encouraging people to think about it in the government. And there is a real underdiagnosis. People don't recognize it. I mean, where you look at diabetes, where half of the diabetics aren't recognized, and sleep apnea is far worse. So it would be nice if you thought about it, because as half of my partners who are treated for sleep apnea would say, we feel so much better that that the treatment is worth it, and there are the health benefits. So in evaluation, we mentioned the thick neck size. Grinding your teeth, bruxism, is also a sign. So when someone tells you you're grinding your teeth and wants to give you some sort of mouthpiece, you may want to look into this instead, because just protecting the teeth isn't actually getting to the core problem, which is a sleep disordered breathing. Clues when you look in the mouth and you can't see the back of the throat. This slide here with the tonsils isn't really accurate because in adults, tonsil size is rarely big enough to occlude. After age 10, the airway gets to be so large that taking the tonsils out is not helpful. But the slide on the right does show a real crowded pharynx, which is a clue. You look in the mouth and you see that, it's a clue. Also, if the tongue is scalloped, it's an indication you're trying to push your lower jaw forward during sleep. So if you look at a tongue and you see that it looks like a serrated knife, that's also a clue. Some people have jaws that sit further back to start, like the image on the left, and there's less distance for the tongue to go to occlude the airway in the back, so they are more likely at a lower weight to have that problem. So sometimes a skinny person who has a jaw that's further back will be more likely to have a sleep disordered breathing and respond to another treatment besides CPAP that we'll talk about in a minute. So there are two types of diagnostic tests. There's the in-lab where you sleep over all wired up, goo cups wires off your head, bands around your chest and your belly, oxygen monitoring, cardiac monitoring, kick monitoring. It's involved, but it's very accurate for people who, might have a lot of comorbidities and we need to see exactly what's happening. For a lot of us, though, the home sleep test is adequate. Some of the things they measure, maybe chest wall movement, maybe definitely oxygen saturation. Airflow is sometimes measured. There are ones that use just the pulse, and they could be quite easy to do at home. And people who really can't sleep in the lab certainly should think about that. Many people who don't have a lot of other disorders like heart failure or strokes you need to look for, or movement problems during sleep, you don't really need an attended study in a lab. So this is some of the wiring. You see the belts there that measure whether the belly or the chest are moving. There's some leads by the nose and mouth to monitor airflow. You don't see the EEG electroencephalogram leads so well, but that's the night in the lab. It's not bad. Most of the labs are by design extremely comfortable, like a hotel setting, and these things you have on look like they're a problem, but I've slept through it with no problem at all, and my wife, who has terrible insomnia, has, so I think anyone can. So how do you treat it? These are the general things. Well, let's go through it. So obviously weight loss for those who are, many of the people are heavy. And when you gain weight, you get fatty tissue everywhere, including around the airway. So the airway becomes more narrowed and it's more susceptible to blockage. So obviously everything we do to try to lose weight is helpful for sleep apnea. Continuous positive airway pressure is the best of the modalities for people who are at least moderately have moderate to severe sleep apnea. There are a million, but this is the slide about what might go wrong with it: nasal congestion, airflow onto the eyes, stomach distension. Some people will swallow air. Claustrophobia. We have ways around every one of those, and it's really almost everyone who needs CPAP can get it. We have lots of different masks. This is an old slide. There are millions of them. We have machines that have settings that make it more comfortable. They're certainly quieter than a snoring person, for sure. They're very quiet indeed. And most of the time, like 95% of the people who get on it do okay. Some quit after a period of time, some won't do it, but it's absolutely worth it. Like I said, half my partners use something like this and for years, and it's worth it. It's worth it in terms of comfort. The other thing is an oral appliance. So I lost a bunch of weight and went from CPAP to an oral appliance. It's basically you go to a sleep dentist on referral. They make an impression of your teeth. These days, that means waving a wand around in your mouth, and they get a digital impression, which they send directly to the manufacturer, who makes a plastic piece that fits over the upper teeth, a plastic piece that fits over the lower teeth, and there's a linkage. So the upper jaw holds the lower jaw either in the place that it is when we're awake or slightly forward. And for people who are mild to moderate and aren't too heavy or have that retrognathia, that jaw that sits back, it's a very good option. It's very easy to travel with. It's a little easier than CPAP, and there's the cleaning is simpler. The surgeries aren't done as much as they were before. These are the things that sort of widen the mouth. If on the left side, they're cutting away the uvula, little upper punching bag that hangs down, and other things to widen the mouth. Done alone, though, frequently the sleep apnea problems and even snoring will recur within 6 months. So if you're going to choose something like that, you probably want to have the oral appliance as well. And this is the new one everyone sees on TV called Inspire. The commercials, though, go way short of what you need to know. This means to get this one, you have to be in the moderate range, not severe, and not mild. You have to have a body mass index that's 35 or less. So sometimes people have to diet before they get it. Then you have to go to an ear, nose, and throat specialist, and they have to inspect your airway to make sure it's the right structure. Then you have to have a pacemaker implanted that runs up to a nerve in the neck. Then you have to have several visits with someone like me where we up the amperage of that pacemaker until it captures your tongue. And then you get to wave the little thing over your chest, which is just a remote that tells the pacemaker to go on in a preset amount of time, let's say 20 minutes. So you wave, 20 minutes later, every time you take a breath in, your tongue sticks out. And your neck balloons. They call it bullfrogging. It does work. For people who can't use CPAP, it is an option. But like I said, you have to have the right degree of sleep apnea. You have to have a weight that's not too high, and you have to go through all those processes. But I do have patients who could not use CPAP who have the Inspire who are very happy. So, again, to promote doing it, CPAP helps with heart health. CPAP lessens the incidence of heart failure and stroke and improves heart failure when you have it, if you have sleep apnea and you're treated. Diabetics need less medication. It's easier to lose weight, which is helpful. Blood pressure, you may need less medications as well. So, who should be tested? Well, anyone who's dissatisfied with their sleep may want to get at least a consultation. And you're sleepy during the day despite adequate hours in bed, you certainly want to think about it. Risk factors we went over before. And people who are in occupations, this is interesting in that before Dr. Dement found that gentleman I mentioned, nobody was being tested for sleep apnea who was operating a train or who was operating a plane. But now it's a standard, if they have any indications they might have sleep apnea, to be tested and treated before they get to do it. And poor sleep is equal to alcohol. It's virtually the same. Some of you who take courses to lower your insurance premiums for your car may already know that because it's frequently mentioned, equal to alcohol. This is an interesting tool. It's a survey called Stop Bang. So the S is, I'll start with this. If you're 50 or older, you already have one of these things. If you're male, you have one of these things. If you're heavy, that's one of those things. And if you have high blood pressure, it's one of those. So, if you're in the audience and you're a 50-year-old man who's heavy, and has high blood pressure, you already should probably be screened. But certainly someone should ask you, do you snore or are you tired? And if those things are true, you're very likely to have it and very likely to benefit. Also, people with sleep apnea, when they're treated, are much more energetic, tend to lose weight. Not that it's a weight loss product. So I'm going to stop there and take questions.
Okay, so there's a question in the chat. Do you see that, Dr. Wohlberg?
There are two questions in the chat that I see. Oh, the cameras. Okay, that's not a question. What about BiPAP versus CPAP? So BiPAP means there are two different pressures, a pressure when you're breathing in and a baseline pressure it never goes below. Sometimes you can take a slightly lower pressure on BiPAP, sort of in between the lower and the higher pressure, and it can add to comfort. Some people actually, in addition to just not being able to breathe, don't ventilate enough and need a bigger spread between the pressure when they're breathing in and breathing out to actually help them get enough air in and out. So some people, in particular, people with lung disease, some with heart disease, and certainly some who are very heavy and have something called obesity hypoventilation, need bi-level to actually help them get good breaths in and out during this period, and they need that lower pressure to keep them open. Okay, so Wendy has a severe score of 87. I don't know if that's a question. Okay. Does sleep apnea increase AFib? Absolutely. Atrial fibrillation. So I mentioned that each time you have a difficulty with, and thank you for that question. Each time you have difficulty breathing, the brain's going, oh my God, this is terrible, and pouring out adrenaline. So if you have a lot of adrenaline around, it's very hard to get out of atrial fibrillation. So people with atrial fibrillation should, most of the time, certainly before they get ablations, should look into sleep apnea, because treating it may be enough without a procedure.
Thank you so much, Dr. Wohlberg. Really appreciate you
You're
being here
welcome.
with us tonight. And for everyone else who joined us tonight, thank you.